talking about the concept of clotting, and our current exemplar is going to be deep vein thrombosis. These are two great videos that you will need to watch so that it'll really help you to understand the competent and incompetent venous flow. For this lecture are to describe the pathophysiology and clinical manifestations of deep vein thrombosis, or DVT, to identify the risk factors, to identify priority nursing diagnosis, to develop a plan of care for the patient with a DVT, and to discuss treatments available. By definition, a venous thrombosis is when a blood clot forms on the wall of a vein, and a DVT is a thrombi located in one of the deep veins in the body. A thrombosis that, although common, can be a very serious development. They occur more often in the lower extremities but can occur in the upper arms. A thrombus that dislodges from the deep veins of the lower extremities become an embolus as it travels up the inferior vena cava into the superior vena cava into the heart to lodge in the smaller pulmonary veins. The patient may experience pulmonary signs and symptoms of shortness of breath, dyspnea, anxiety, diaphoresis, impending death, depending on how large the embolus is. Or venous thromboembolism is the term that describes the occurrence of a DVT to PE pathology. This occurs more often as a postoperative complication. Out of 200,000 hip surgeries, up to 800 patients will die from a pulmonary embolism within 3 months, usually within 1 hour of symptom onset. The embolus can lodge in a large branch of the pulmonary vasculature, which could cause sudden death, or in a smaller branch and be nearly symptomless. This video shows the process, so take time to watch it. The pathophysiology of DVT was described by Virchow in 1846 as coming from a triad of possible changes in the venous system. The triad includes changes in the vessel wall, such as injury or surgery, changes in the pattern of blood flow, such as venous stasis, and changes in the constituency of the blood, as in hypercoagulability. A thrombus can be caused by one element of the triad or involve all three. Those different conditions or pathologies that affect each element of Virchow's triad. Venous thrombosis is also associated with an inflammatory process. When a thrombus develops, inflammation occurs around the clot, thickening the vessel wall. This video shows how inflammation promotes the process of thrombus formation. The most important risk factor for nurses would be as postoperative complications due to the physiological response to surgery of inflammation, along with decreased mobility. The highest incidence of clot formation occurs in patients who have undergone hip surgery, total knee replacement, or open prostate surgery. Any prolonged immobilization, such as in a car or airplane trip, or sitting for long periods in front of a computer, can lead to venous stasis. Many cancers can lead to hypercoagulation. Cancer patients constitute 15 to 20% of the patients diagnosed with DVTs. And depending on the type of tumor, extent of malignancy, type of cancer treatment, and presence of other risk factors, 1 to 25% of patients with malignancy will develop a thrombosis. trauma can also lead to a thromboembolic event with high mortality as it complicates the primary injuries. Evidence from clinical trials consistently show that the risk of thrombosis is at least doubled in women taking hormone replacement therapy and may be increased by up to about 3.5 times. In some of these trials, but not all, the increased risk was confined to the first year of use. So we want to identify and treat all DVTs early so that we can prevent the occurrence of a thromboembolic event, especially a pulmonary embolism. The initial symptom of a DVT is usually pain, which could be in the calf, thigh, or groin. Sudden onset of unilateral swelling of the leg is a symptom. Warmth and redness at the site is also common. Homan's sign, which is pain with dorsiflexion of the foot, occurs in only a small percentage of those afflicted, and so it is deemed an unreliable indicator. As we examine the painful area, we need to compare one side to the other. We need to palpate the site, observing for induration or any firmness to the tissues. Look for warmth, redness, and edema. Blood pressure and heart rate may or may not be outside of the normal range. We do not want to massage the area. Primary prevention to the public in general includes regular exercise, smoking cessation, adequate hydration, avoiding prolonged sitting, and wearing support or TED hose. Post-operative interventions include, as number 1, early ambulation or out-of-bed activity, if at all possible. Wearing TED hose or compression stockings, especially when ambulating. Using Venadine or SCD, sequential compression devices, when in bed. Reminding the patient to not cross their legs and to do leg exercises while in bed. Prophylactic anticoagulant therapy with Lovenox or heparin injections are often included in the plan of care to decrease the risks of postoperative DVTs. If a DVT is suspected, the first diagnostic test usually ordered is a Doppler flow or venous duplex ultrasound study. A negative D-dimer also can help to rule out the presence of a clot. An MRI is more effective in diagnosing DVTs in the pelvis and as effective as a venogram in diagnosing DVTs in the thigh. A cuff impedance plethysmography uses blood pressure checks at different places in the leg to identify possible blockages. Venography used to be the gold standard investigation for DVTs, but due to its invasive nature, it is no longer a first-line investigation. Radio-opaque contrast is injected into the dorsal foot vein to visualize thrombi under X-ray control. The procedure carries a small risk of venous thrombosis or allergic reaction to the dye and may be technically difficult in patients who have poor venous access. The main goals of treatment for DVT are to prevent the blood clot from becoming larger, to prevent the blood clot from traveling to the lungs, to prevent post-thrombotic syndrome that can occur if left untreated, where pain, sores, and extensive swelling occurs, and finally to prevent blood clots from reoccurring. To prevent the thrombus from becoming an embolus, the area is not massaged and strict bed rest is maintained. Elevation of the extremity and wearing of TED hose or compression stockings both help facilitate venous blood return. Intermittent or continuous warm soaks to the affected area may help with pain and swelling. Breathing exercises with an incentive spirometer is an important intervention, as in this way they can exercise the pulmonary vasculature to move the blood and oxygen through the system. Antithrombotics include the antiplatelet and anticoagulant drugs that, by hindering the clotting cascade, they slow down clotting, they reduce fibrin formation, and they prevent clots from forming and growing. Thrombolytic drugs are in a way stronger and act to dissolve the clots once they have formed. Anticoagulants are often used in the treatment of DVT. Lovenox and heparin are given subcutaneously, and heparin is given as a continuous infusion by IV drip also. Before the heparin is discontinued, the patient can be started on warfarin because it needs time to build up to a therapeutic drug level. Therefore, the patient will be on both heparin and Lovenox for a short time. Heparin works faster than warfarin, so it is usually given in situations where an immediate effect is desired. Both are able to prevent the extension of a previously detected blood clot. Usually patients switch to warfarin PO when long-term anticoagulant therapy is recommended. The bleeding time for heparin is determined by the lab APTT, as you know, and the bleeding time for warfarin is determined by the PT and INR. The antidote for overcorrection of heparin is protamine sulfate, and the antidote for warfarin is vitamin K. Warfarin is the most widely used anticoagulant, but because everyone differs in their physiological makeup, dosage requirements differ from person to person. Blood clotting is a natural protective mechanism employed by the body to seal off damaged blood vessels. So any medication that alters this natural protective mechanism must be carefully monitored. People taking warfarin must obtain a blood test every 2 to 4 weeks to ensure that their blood is at the most therapeutic level to the correct degree without bleeding complications. Thus, the INR may be repeated several times a week at the beginning of treatment to assure the optimal therapeutic level is achieved and maintained. Generally, an INR of 2.5 to 3 or 3.5 indicates that the patient is receiving the correct dose of warfarin. INR values greater than 5 can be dangerous, and those below 1 indicate no warfarin effect. Changes in the amount of vitamin K in the diet can alter the metabolism of warfarin, so it is important to keep the amount of vitamin K in the diet consistent. The highest amount of vitamin K is found in green leafy vegetables like broccoli and spinach. An increase in vitamin K intake will cause the INR level to drop, and a decrease in vitamin K intake may increase the INR. Alcohol should be limited to 1 drink per day, as it can increase bleeding tendencies, as can cranberry juice, taking vitamin E, garlic, ginkgo biloba, and other natural, quote, blood thinners. This chart just shows foods that are high or moderate or low in vitamin K. Depending on the severity and size of the blood clot, sometimes the physician may prescribe a thrombolytic to dissolve the clot. Again, depending on the situation, sometimes surgery is indicated to remove a blood clot from a leg vein, especially in cases of acute venous occlusion and severe pain. Venous thrombectomy has been known to remove some of the vein lining along with the clot, and it can result in an increased risk for repeat clot formation. An inferior vena cava filter may be used for patients that cannot take anticoagulant therapy. These are two nursing diagnoses: risk for ineffective tissue perfusion, peripheral, related to interruption of venous blood flow, and acute pain related to physical injury agent, which is the thrombus.